You're listening to the Future Tech Health Podcast with Richard Jacobs. Until I reached age 40, I never realized the obvious, that we all have medical issues, or we at least have a family member or close relation that has, or will have them in the future. Medicine and biological systems are the final frontier. Until we've conquered death, figured out how life began, cured cancer, and understood our purpose in the universe, there's a heck of a lot to talk about when it comes to our health. Future Tech Health means I'll be covering futuristic topics that are actually already in clinical trials, or even starting to appear on shelves or by prescription, or available for your own use. We dive deep into stem cells, CRISPR-Cas9, the science of sleep, epigenetics, medical testing, cancer, ketogenic diets, stem cells, aging, regenerative medicine, and more. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a serious medical problem. Remember, however, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you enjoy the podcast, please listen, subscribe, like, and share it with friends. Thank you. You're about to listen to my podcast with Paul Moayyedi, a very distinguished person. I can't believe he has 402 peer-reviewed articles and has been cited so many times. We had an interesting call. We talked about the microbiome and how that may be different in people with irritable bowel syndrome, Crohn's disease, etc. And Paul seems to be privy to many studies, a lot of which his hand has been in, to elucidate what's going on. Why do people have irritable bowel? Why do they have Crohn's? And how does the microbiome play a role? What species of bacteria are there or not there when people have these problems? How can we intervene? You may have heard of fecal transplants. Well, do they work? Paul's got privy to some studies where he talks about what's happened and why do they work. We get into that a little bit. So it's rare to have someone with this amount of knowledge and publications. So you definitely want to listen in. And I encourage, if you're not getting all the information you want and you want to go deeper, obviously Paul again has over 402 peer-reviewed articles. He may be amenable to you reaching out, but certainly got an unbelievable wealth of knowledge about microbiome. If you have Crohn's or IBD or any of these gastrointestinal related disorders, you're going to want to listen in. Hello, this is Richard Jacobs with the Future Tech and Finding Genius podcast. My guest today is Dr. Paul Moayyedi. He qualified from Bristol University and obtained a PhD and Master's in Public Health from the University of Leeds. He moved to McMaster University in 2004 and was the director of the Division of Gastroenterology at McMaster until 2017. He holds the Audrey Campbell Chair of Ulcerative Colitis Research and is currently the Assistant Dean of Research at McMaster. Amazingly, he's published 402 peer-reviewed articles and has been cited over 49,000 times with an H index of 106. He was the co-editor-in-chief of the American Journal of Gastroenterology 2010 to 2015. He's currently joint coordinating editor of the Upper GI and Pancreatic Disease Cochrane Review Group and a proponent of evidence-based medicine. Many credentials. Looking forward to speaking with him today. We're going to be talking about the microbiome and its impact on irritable bowel syndrome and other associated disorders. Well, Paul, thanks for coming. How are you doing today?
I'm all right. How are you?
Good. I'm glad to talk to you. I saw that you've had 400 plus publications, which is amazing. And, you've been in this field for quite a long time. What's the current work that you're doing? What questions or answers or things are you looking at right now?
Well, we're really interested in how gut bacteria affect health. I'm a gastroenterologist, so the focus is, of course, on gastroenterological diseases. But I'm also collaborating with many other disciplines, including psychiatrists, because we feel that gut bacteria also influence our mood, and that if we change them, we might be able to help anxiety and depression. So I'm leading a network across Canada called the Imagine Network, which is studying both GI and psychiatric diseases.
So is your focus exclusively on the gut microbiome, or is it more on the physiology of the different parts of the gut?
So, no, my focus is not just the microbiome, although that's certainly a very worthwhile area of research and involves a lot of what I do at the moment. But I'm someone who believes in a movement called evidence-based medicine. So it's about designing the right study to answer questions about how we improve health. Even today, there's a lot of medicine that's just practiced because of belief rather than true evidence that something works. So I do a lot of studies trying to improve our understanding of what treatments work and what don't. But a large focus of that at the moment is on the microbiome.
When people talk about the gut microbiome, I mean, the gut is, where is the gut? There's the rectum, there's the sigmoid colon, and the whole colon itself, and the cecum, the small intestine. How have anyone sampled, when they sample the gut microbiome, where are they sampling from? Usually it's just the rectal part, and where are the different niches along, let's say, the colon? Have we even gone far into the colon to see what's there, or is it not possible?
It's relatively straightforward to look at the colon, although there are challenges there too, as I'll talk about in a minute. But what I would say is most of research into gut bacteria relates to the stool. Obviously, it passes down the gut and comes out in stool. So it's the obvious thing to study and the least invasive. Although, of course, that only gives a snapshot of what is going on in the body. And as you say, if we look at the colon, that's the large intestine, that is teeming with bacteria. And the nearer you go to the rectum, the more bacteria there are. But the whole of the colon has the highest concentration of bacteria in the planet in our human colons. And it is said that there are more bacteria in our colons than stars in the galaxy. And the bottom line is it's very difficult to study because there's just so much information. But there does seem to be some changes as you move from the right side of the colon to the left, which is closer to the rectum. But what those changes really mean, I think it's fair to say we don't know. When you go into the small bowel, that's where all the digestion takes place. There are a lot less bacteria there, but there's still lots. And some of them are important for our digestion. As you move further up the gut into the stomach, there is far less there. The only one we know actually lives in the stomach is a bacteria called Helicobacter pylori. But really, there are many others you see, but whether they're just passing through or truly colonizing the stomach is uncertain at this stage.
Well, have there been studies that have taken, it's very gross, but a stool, the whole stool itself, and cut into the middle of it and seen if there's different bacteria in there versus the outside? Maybe they'd be remnants of part earlier in the colon. Or, if you looked at someone that has diarrhea versus, is constipated, how different is the stool and the bacteria in it?
Mostly when you analyze this, you homogenize the stool. So I'm not sure anyone has looked at the middle versus the outside. Although my guess is if you did that, you might culture more anaerobic. That's bacteria that don't like oxygen in the middle compared to the outside, where of course it's exposed to oxygen. But that's just a guess. I don't think anyone's looked at that. But you're right. If you have diarrhea, one would expect the bacteria to look different, and they do. But you don't know if that's because of the diseases that are causing the diarrhea, or just a consequence of having a rapid transit of your stool. We're only scratching the surface at the moment, and we don't really know. And in terms of does the stool represent the colon, the answer is if you do biopsies, take small samples of tissue from the colon when you do a colonoscopy, there are some differences, but it seems that stool is reasonably representative. And even when we sample all around the colon, we don't know that that is the truth, because, as you say, in order to do a colonoscopy, we give people diarrhea. So, what we're looking at is also a function of the bowel prep that we've given. So knowing what's truly inside us is more of a challenge than you might think.
Well, I wonder if you could characterize the bacteria in the stool and determine, like, let's say you do a colonoscopy, you see someone has polyps or they have colorectal cancer, and then you go back and you analyze their stool. I wonder if you could tell from the stool if they have polyps or they had colorectal cancer, because if you could reliably do that, then you might not need colonoscopies anymore at some point. You could just use stool samples.
Actually, that is something one of my colleagues, Dr. Selina, in collaboration with the engineering department at McMaster, is looking at a stool test that could rival the FIT test, which we normally use as a stool test to diagnose polyps and colon cancer. But as yet, we can't say that. And this is true of many diseases where you look at. Is when people study it, they find that people with colon cancer, for example, have a different gut bacteria to those that do not. But everyone comes with a somewhat different story. And it's because of all that information I was talking about, that vast amount of bacteria. Usually these are just small numbers of patients studied. And you can create any story you like, but you've just got so much information there, you can't be sure that story is true. And that's why when different researchers look at this problem, they come to different conclusions, all saying it's different, but different in different ways. And this is why we have this Imagine network in Canada, which aims to recruit 2,000 people with Crohn's disease, 2,000 with ulcerative colitis. These are inflammatory conditions of the bowel, 2,000 with irritable bowel syndrome, a more common problem causing pain and change in bowel habit, 2,000 people who are healthy. When we've got all 8,000 people, we hope we will have much more information to really drill down what the true differences are and what's just happening by chance.
So what in particular are you working on right now? What's the latest that you're trying to figure out?
Well, that we're halfway recruiting that study that I'm talking about, this large group of people who are kindly volunteering to take part in this study. And our focus particularly relates to both irritable bowel syndrome, but also a thing called inflammatory bowel disease, ulcerative colitis and Crohn's disease. These effects predominantly start in young adults and teenagers. And we don't know what causes it, but once you have this disease, it's lifelong, associated with, in the case of Crohn's disease, severe pain and diarrhea. Ulcerative colitis, mainly just diarrhea, but sometimes very severe and really impacts on the quality of life. And the drugs used to treat it, called biologics, are very expensive and have sometimes have side effects and do alter the immune system. So could have serious side effects related to that in some people. That's not to say that they're not miraculous in some patients, but in others, they really struggle with their disease. And we feel the cause is in the gut and likely to be bacteria, virus, or fungus that's sitting in your gut driving this disease. If we can identify that, we might be able to cure these diseases and help millions of sufferers across the Western world who have this.
It seems like since everyone's microbiome is different, it would make sense to profile someone if you could when they're healthy, and then when they're sick, continue to profile them to see the change, and that might give you a specific plan for them. These microbes seem to have disappeared. These are now in abundance. Can we somehow restore that previous balance for them that worked?
That's a very good idea, and one that in Canada we have been doing for about 15 years now. That is called the GEM project. GEM stands for Genetics, Environment and Microbiome. That's led by Dr. Ken Kreuteru from Toronto. I'm also involved in that, but Dr. Kreuteru is leading that study. And he has collected 5,000 first-degree relatives, that's brothers and sisters, and parents or parents of an index case with Crohn's disease, and hopes and collects their stool at baseline. And most of them will not go on to develop disease. But if you have a first-degree relative with the disease, you're more likely to develop it. And we were predicting that over follow-up, about 75 people out of those 5,000 would go on to develop Crohn's disease. And indeed, that has happened now. So we're analysing that to see what the differences are. As yet, we do not have data on this, but we will in the near future. And that may well give us some of the answers you are talking about. But again, I would emphasise that doing that makes sense, but you need so many people. And with 5,000 high-risk people, we're only getting 75 with Crohn's disease, which is great. It means that most of the people participating are not suffering, but also means that we don't have that rich information that I was talking about with the other studies. So the two are complementary. I suspect when we do the analysis of the GEM study, we will have interesting possibilities, but we won't have enough patients with the disease to be certain that this microbe is causing the Crohn's in this case. But
I don't think we can ever be certain. I mean, 75 seems to be a lot more than a lot of clinical trials have.
Yeah, but you need, most of research is based on being reasonably certain. So we often talk about p-values of less than 0.05, which means there's a 1 in 20 chance that the observed differences you have are by chance. If you go on less than that, there's all sorts of hypotheses you're throwing up all the time that are just not real. And even at that level, there are some that are not real, but hopefully others that are. So that is why we're cautious, because if you have lots of interesting possibilities, all you do is chase your tail looking at hypotheses, most of which aren't true. So you've got to set the bar reasonably high, not to be absolutely certain, that's never possible, but to be reasonably certain that this might be real. A bit like throwing a dice. If you throw a double six, that could be a chance. If you do it a lot of times, then it's likely that the dice are loaded. It's that sort of thing that we're trying to get to the bottom of when we do these studies. Well,
how many people do you think it would take, or who knows, until the data comes in to give you a strong signal that Crohn's is coincident with a certain bacteria?
Yeah, just knowing what we know now about the microbiome rather than what we did 15 years ago, my impression is, to be absolutely certain, we're going to need a lot more than 5,000 people followed up. But that's also, it was a real struggle to do that. Dr. Croter has to be congratulated for collecting that number of people, as well as all the investigators contributing to this in Canada, England, the US, and Israel. But the bottom line is, the more certain you are going to be with the numbers, the more impossible the study becomes. So this is why we're attacking it from different angles. On the one hand, we're doing the study you suggested. On the other hand, we're also looking at people who already have the disease. There we can get much bigger numbers more quickly, but we have less certainty of what is the cause and what is the consequence of the disease. And then finally, we can do interventions such as fecal transplants, which we are also doing in Crohn's disease and ulcerative colitis, changing the gut bacteria and looking to see who responds to that treatment and why. What about their bacteria changed to bring about that success? And we were the first in the world to start a randomized trial in fecal transplants in ulcerative colitis, and we're almost finished another one now. And hopefully we will also learn a lot about what is driving these diseases from these types of studies.
What's been noticed with fecal transplants? Have you collected stool, done a fecal transplant, and then collected stool again to see a day later or a week later, what happens to the person's gut microbiome?
Yeah, so the design of the first study was that we took 75 people and with ulcerative colitis, with active disease that had diarrhea, often with blood in it, and feeling unwell, and either had elected not to have the sorts of treatments I was talking about, or the treatments they were taking were not working. And then we randomized them half to have fecal transplants from a healthy donor, and we gave it via an enema once a week for 6 weeks. And the other half got a placebo, which was water. Now, you may think that would be obvious to the person, but actually, when we're talking about fecal transplant, it isn't truly feces we're giving, it's actually fecally contaminated water. So, of course, when you put water up there, it comes out fecally contaminated anyway. That was the design, and we did show success. A quarter of the people went into remission at 6 weeks. It's not miraculous like the treatment of C. difficile, but nevertheless, for those people who responded, it was great for them. And actually, that is as good a success rate as you get with biologics, some of which cost $10,000 to $20,000 a year to treat a patient with, whereas obviously stool is a lot cheaper. So this is certainly interesting. It's a small number of patients. This is not certain. Which donors to use, how long to give it for, etc. But 2 groups in Australia, 2 different groups have confirmed our findings. And we believe this could be an interesting approach for sufferers of ulcerative colitis. And we're just trying to refine the questions so that, or our understanding of how this works, so that we can make it better in the future. And we're also starting trials in Crohn's disease, this time with capsules of donor feces, obviously carefully encapsulated, so it's only released in the small bowel. We will see if that is a success as well. That study is led out of Edmonton by Dina Cow and Karen Madsen.
But what did you see when you looked at the stool of the people that had the fecal transplants? What were the main differences? Were there different bacteria that predominated? What jumps out at you when you compare the stool of the people before they had the transplant and after?
Right. Well, what jumps out at you is, first of all, transplant is not a great name, although it's with us now, so it's stuck. But nothing is being, transplant. When you transplant a kidney, the other person's kidney now is in you. With stool, it isn't that you gain the other person's stool. Our best guess is you gain about 10% of the organisms from the donor stool. So there is a shift in your gut bacteria, but it's not a wholesale shift. There's just some organisms that you then keep from the donor and lose from yourself. Again, a lot of these are different in different people, so it's difficult to give any firm conclusions about what is driving the success. Although my colleague Mike Surratt, who I am collaborating with, a microbiologist at McMaster, his team are actually culture enhancing the stool, which gives you a much richer picture than you get with a normal 16R sRNA, which is sort of technique where you amplify the DNA and RNA of the bacteria there, or metagenomics, which is a different way of doing that. Both of those give a rich picture, but you get it much richer still if you culture that, although it is very expensive and time consuming. And they've done that with our donors and looking at what part of the donor is going to the recipient. That work is yet to be published, but it is providing interesting data.
Have you looked at, I guess you could look at 3 things: the bacterial constituents of the donor, the fecal donor, the bacterial constituents of the recipient before the donation, and then after. So if you look at those 3, what was observed that jumps out at you?
Yeah. So when we look at this overall, we realize that the word transplant is not a great description, because it's only about 10% of the donor bacteria end up taking in the recipient. And so the recipient's bacteria change somewhat, but there's not a wholesale change towards the donor. And others that have done this have shown a similar thing. Now, obviously, it's interesting to look at the 10% that do take, particularly in those that respond versus those that do not. And so my colleague, Dr. Mike Surrett, a microbiologist at McMaster University, has been evaluating the donors in great detail. So he and his team can culture most things in the stool, which greatly enhances the resolution of what you're seeing in the stool. Usually you do it with DNA and RNA extraction techniques, but when you actually grow the bacteria, you can get a lot more information. So he does that with the donors. It is very expensive and time consuming, so it is difficult to do that with the recipients. But we certainly are getting some interesting signals, but that work is not published yet. So I can't really divulge anything more than that, other than there are changes. And I think it's safe to say we still haven't got a cure yet, but we're inching we are further understanding what these differences are, which hopefully in the future will lead to better treatments for patients.
Have you looked at the metabolomics of the profiles to see? Oh, okay. The donor, they were producing these metabolites, and the recipient wasn't, and now we've added back in some necessary pathways and changed them.
So that's a great question, and we didn't do that, not because we didn't think it was important, but just because it's difficult to get funding for this. We're not a rich drug company, so pragmatically, we could only afford to do so much. So we focused on the microbiome rather than the metabolomics, what the gut bacteria are producing. And usually you look at that in the urine. We are doing that in the bigger study that I talked about before, where in these 8,000 people, we will have metabolomic data as well as microbiome data.
Oh, nice.
So we'll have a much richer data set there to look at what the bacteria are, what the metabolomics are, and how active their disease is, and also compare with healthy controls, and hopefully see what is different. The other thing about this large study is it is a cohort study, so we're following them up over time. So we will see them as some of them sadly will relapse in the disease and get worse. Some will get better, and we can see what the changes in the microbiome and the metabolomics are in that setting. So we hope that will give useful information, and I think. In an ideal world, you're absolutely right. It would be good to do this with fecal transplants as well.
So what do you think is going to be important in the future studying the microbiome? What are some huge overarching goals? Is it to do things like fecal transplants to modulate people's microbiomes, or is it more to change their diet? What do you think will be the big levers on how you can affect people's health positively?
So I think diet is important, and we are studying the patient's diet with a food frequency questionnaire in this last study that I was talking about. And yes, it will modulate the microbiome, and it may be both farming practices and our dietary preferences are what is leading to the rise in inflammatory bowel disease in Western populations. And now that countries like Japan are becoming westernized, they're starting to see ulcerative colitis, and I would predict they'll see Crohn's disease in the future as well. So diet is important, but I do feel once someone has the disease, removing certain things from the diet, it'll all be too late. And I feel that the best way of treating these diseases, both ulcerative colitis and Crohn's disease, is more effective therapy at changing gut bacteria. At the moment, the most promise is with fecal transplants. That doesn't mean that will always be the case. If we can find an organism that is driving these diseases, we can use antibiotic. But, understanding is not that deep or the situation is more complex, we probably will be looking at a form of gut modulation of bacteria with other bacteria. So some people are using curated organisms, some people are using fecal transplants. I'm not sure which will win, but my hunch is that nature is going to be the best treatment, and in the future we will be I believe, using more fecal transplants to treat these diseases, and working out how to do it better and which groups are going to do well with this. And basically, hopefully, help a lot of people with these diseases. And as I say, as we collect all this microbiome data, I hope we will end up curing these diseases. I'm a big fan of the current therapies. They are great, but they all modulate the immune system, and they're not focusing on what's driving the immune system in the first place. And that is what I think will lead to understanding a cure for these diseases, which is why I'm so excited by the microbiome. So I think in changing the microbiome, the key will be to modulate it directly, not indirectly by changing the diet, but more directly by antibiotics or fecal transplants. I don't think antibiotics are sensible at this stage because we don't understand what's driving the disease, and indeed it may be too complex to treat with antibiotics. It may not. Who knows what the future holds? But certainly from our experience, fecal transplants, as we understand how they are working, may well come into more of the mainstream in these diseases as another option for patients. I would emphasize not yet, it still needs more research, but in the future, this may be a great option for some patients, and hopefully this early successes we're having will just be enhanced as we do this more.
Well, very good. Well, Paul, what's the best way for people to dip their toe in and find out about some of the work that you're doing? How can they get in contact?
So I would contact the website, where you'll see a vast array of studies in these areas, including the large study I talked about and the fecal transplant studies, but others as well. So I would encourage people to go to our website, which is www.imaginespor.com. That's IMAGINESPOR.com. And there you'll get all the contact details, and if you're in an area where we're doing this, who to contact in that area.
Well, very good. Okay, no problem. So I guess, Paul, thank you for coming. I appreciate it, and you're doing good work, and it's going to be amazing to see what these large-scale studies that you come up with.
Thanks very much, Richard. It's been great talking to you.
You're listening to the Future Tech Health Podcast with Richard Jacobs. Until I reached age 40, I never realized the obvious, that we all have medical issues, or we at least have a family member or close relation that has, or will have them in the future. Medicine and biological systems are the final frontier. Until we've conquered death, figured out how life began, cured cancer, and understood our purpose in the universe, there's a heck of a lot to talk about when it comes to our health. Future Tech Health means I'll be covering futuristic topics that are actually already in clinical trials, or even starting to appear on shelves or by prescription, or available for your own use. We dive deep into stem cells, CRISPR-Cas9, the science of sleep, epigenetics, medical testing, cancer, ketogenic diets, stem cells, aging, regenerative medicine, and more. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a serious medical problem. Remember, however, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you enjoy the podcast, please listen, subscribe, like, and share it with friends. Thank you.